Hi guys, good morning everyone. So today we're going to start with UVEA quiz discussion that we had yesterday. So shall we start with the first question? So the first question is most common cause of acute anterior uveitis. Okay. Uh, so what is the most common cause of acute anterior uveitis? Now, there is a confusion between idiopathic and HLA-B27. Okay. Now, HLA-B27 is the most common cause. It's not idiopathic. Okay. So, acute anterior uveitis, you always have a doubt between two options. See, we have four options: idiopathic, tuberculosis, HLA-B27, Behçet's disease. Now, tuberculosis, Behçet's disease, you can easily rule out, but you're always confused because it's kind of little controversial between idiopathic and HLA-B27. But textbook says, latest edition says it is HLA-B27. Okay, so please note it down. The most common cause of acute anterior uveitis is HLA-B27, right? You all know HLA-B27, and the most common cause of HLA-B27 associated uveitis is ankylosing spondylitis. All right. Okay. Now, primary site of inflammation in anterior uveitis. See, when I say anterior uveitis, it is either iritis or cyclitis, that is your pars plicata, right? Or involvement or iridocyclitis. Most of the times it is iridocyclitis when we say anterior uveitis. So the primary site of inflammation is neither iris nor the ciliary body, the pars plicata. The primary site is the cavity. Okay, so the cavity is always the primary site of inflammation. So in this case, the cavity that is related to the iris and the pars plicata is your aqueous humor containing cavities. So it is aqueous humor. Okay, so the primary site of inflammation in anterior uveitis, please remember, it is aqueous humor. Similarly, the primary site of inflammation when we talk about intermediate uveitis. So in intermediate uveitis, again, the primary site of inflammation is the vitreous. Okay, so it is not the pars plana when you talk about intermediate uveitis. So in that case, it would be vitreous. Now in anterior uveitis, the primary site of inflammation is aqueous. Okay. So the options were cornea, pars plicata, anterior chamber, and iris, right? So anterior chamber containing the aqueous humor. So anterior chamber is the primary site of inflammation in anterior uveitis. Is that clear? So aqueous humor or anterior chamber, because posterior chamber is very negligible space, so it's not really posterior chamber. So anterior chamber, where we look for the cells, inflammatory cells, where we look for the flare. So the site of activity is aqueous or anterior chamber. Is that clear to everyone? Alright, now the next is hemorrhagic uveitis. Where do you get hyphema in case of uveitis? Most commonly it is herpes varicella zoster, VZV. Okay, varicella zoster virus. You can also get it in megalovirus associated uveitis these days, but most commonly it is varicella zoster virus. Okay, hemorrhagic uveitis, Behçet's disease, sarcoidosis, varicella zoster, multiple sclerosis. Okay. See, Behçet's disease, you get a hypopyon which is described as a transient or a vanishing hypopyon. Okay, it disappears. It's a fleeting hypopyon. But it does not contain blood cells. There's no hyphema there. Sarcoidosis, yes, you might get hypopyon, but there's nothing characteristic about the hypopyon itself. Varicella zoster. Okay, so that is the answer. Varicella zoster virus is the typical cause of your hemorrhagic uveitis. Good morning, BO. You were missed yesterday. How are you? I hope you're doing well. Okay, filamentous keratic precipitates are seen in filaments. See, normally keratic precipitates are like small dots, and these will have little extensions. Okay, so that is what is called filamentous keratic precipitates. Okay, so filamentous keratic precipitates are also known as, what are they also known as? They're also known as stellate keratic precipitates. Where do you get stellate keratic precipitates? Where do you get stellate keratic precipitates? Chinna accident, yeah. So, so the neck is, I have to keep it immobilized for some time. I guess I should be okay. Right. So where do you get stellate keratic precipitates? Stellate keratic precipitates are found in which condition, guys? It's seen in Fuchs heterochromic iridocyclitis. Okay, so stellate keratic precipitates. Keratic precipitates basically are a hallmark of anterior uveitis. Okay, hallmark of anterior uveitis. Thank you, Bu. Thank you so much. So, keratic precipitates are hallmark of anterior uveitis. Okay. Now, the stellate or filamentous description of the keratic precipitates are found in Fuchs heterochromic iridocyclitis or Fuchs uveitis syndrome. Okay, so what is the other name for stellate keratic precipitates? Filamentous keratic precipitates. All right. Okay, a young adult male presents with acute anterior vision and low back pain. So this is typically the HLA-B27 uveitis. Okay, so acute, and they've already given us acute anterior uveitis and a low back pain. They've not even told us that there is redness, photophobia, decreased vision. Given us a diagnosis that there is acute anterior uveitis and there's a low back ache. So this is most commonly associated with, yes, very good, Bio. This is the ankylosing spondylitis associated HLA-B27 uveitis, anterior uveitis. So the cause Reiter syndrome, ankylosing spondylitis, psoriatic arthritis, Behçet's disease. The answer is ankylosing spondylitis. Okay. Now, hyperchromia of iris is seen in all except hyperchromia. Hyperchromia means increased pigmentation of the iris. It is seen in all except, see, nevus of ota. Nevus of ota, yes, there will be increased pigmentation of the iris on that side. Siderosis bulbi. Siderosis bulbi is when you have iron foreign body inside the eye and that is causing toxicity, toxic symptoms or signs, features in the eye. So in that case, again, you can have hyperchromia of the iris, okay, increased pigmentation of the iris. Congenital Horner's syndrome. See, Horner's syndrome itself, nothing to do with the color of the iris. Yeah, it's nothing to do. But when you talk about congenital Horner's syndrome, in congenital Horner's syndrome, the color of the iris will be lighter compared to the other side. Yes, so whichever side there is congenital Horner's syndrome, that side, the color of the iris will be lighter. Our question is asking about hyperchromia seen in all except. So that means where do you see hypochromia of the iris? Correct. So hypochromia is seen in congenital Horner's syndrome. So that is our answer. Anyway, what is the last option? Sturge-Weber syndrome. Sturge-Weber syndrome where you have portwine stain on one side. So that side again you can have hyperchromia of the iris, and also in Sturge-Weber syndrome, if you look into the fundus, you can see choroidal hemangioma, might see, and the patient is susceptible to secondary open angle glaucoma as well in Sturge-Weber syndrome. Okay. Right. Headlight in fog appearance is seen in posterior uveitis due to, even if they say seen in, we have only one answer. They also given us posterior uveitis due to. So headlight in fog appearance, guys, it's important for FMG exam as well, the upcoming FMG. So yes, headlight in fog appearance is seen in toxoplasma posterior uveitis. And toxoplasmosis is the most common cause of posterior uveitis. Okay, what is the most common cause of posterior uveitis? Toxoplasmosis. Very, very important for FMG. Most common cause of posterior uveitis is toxoplasmosis. And in toxoplasmosis, what is the appearance that you will get? You will get a headlight in fog appearance. Headlight in fog appearance. That is because of the severe vitritis and the chorioretinitis. Okay. So there is a chorioretinitis and there is vitritis. All right. Okay. Now next question. Sunset glow fundus is seen in. Sunset glow is, yes, very good, Bu. Toxo. Yes, very good. So sunset glow fundus of sunset glow appearance. So there will be small hypopigmented areas in the fundus because of choroidal hypopigmentation. Yeah. So where do you get hypopigmentation in the skin? In vitiligo. Yes, you get hypopigmentation in the skin in vitiligo. Vitiligo and eye. What is that condition where you have eye condition and vitiligo? And therefore, we also have choroidal hypopigmentation resulting in sunset glow fundus. So what condition is it? Yes, very good, BU. It is VKH syndrome, Vogt-Koyanagi-Harada syndrome. Okay, Vogt-Koyanagi-Harada syndrome. The patient will have vitiligo. Patient can have sensory neural hearing loss, and patient can have serous retinal detachment, and also patient can have, among other findings, can have, what is the question? Sunset glow, appearance of the fundus. Is that clear? Okay. And what is the treatment of choice for VKH? Steroids. Give systemic steroids. Yeah. A 30-year-old patient presents with redness, photophobia, and decreased vision in the right eye. Okay. So there is redness, photophobia, and decreased vision. Examination shows ciliary injection. What is ciliary injection? Ciliary injection means your circumciliary congestion or your circumcorneal congestion. That only is ciliary injection. Okay. Hazy cornea and irregular pupil. What is the most likely diagnosis? Why is a hazy cornea? I'll tell you. Okay. So what is the most likely diagnosis? Now let's look at the options. Okay. Option A, conjunctivitis. Why would you have photophobia and a simple conjunctivitis? Why would you have decreased vision in conjunctivitis? Why would the cornea be hazy? There's no mention of discharge or anything regarding conjunctival symptoms. Redness. And you will not have circumcorneal redness in conjunctivitis, no? You will have a diffuse redness with maximum redness towards the fornices in case of conjunctivitis. Please remember that. When you have keratitis, uveitis, anterior uveitis, then you will have circumcorneal congestion, okay? In conjunctivitis, there will be a diffuse congestion, and the congestion will be more towards the fornices, not around the limbus. So the conjunctivitis is ruled out. Posterior uveitis. See, posterior uveitis generally is not going to cause redness unless there is a spillover anterior uveitis, very fulminant, and it is spilling over to the anterior segment. Otherwise, there is no redness. Decreased vision, yes. Why would the cornea be hazy in a posterior uveitis? See, posterior uveitis is a choroiditis, chorioretinitis, neuroretinitis also. It comes under posterior uveitis, a periphlebitis, a retinal vasculitis. They come under posterior uveitis. So you will not have any redness. You will not have hazy cornea. And pupil also will be normal. There will be no findings in the pupil in posterior uveitis. So ruled out. Anterior uveitis looks like mostly. Anyway, let's look at option D. Acute congestive glaucoma. See, acute congestive glaucoma, I can have redness, I will have pain, might have photophobia. There will be a sudden decrease in vision. Cornea hazy. Yes, agreed. Why cornea hazy? Acute congestive glaucoma, the intraocular pressure will be high and the cornea will become edematous. Agreed. But why would there be irregular pupil in acute congestive glaucoma? No, you'll have a dilated pupil. Yes, typically a mid-dilated pupil. It's not an irregular pupil. So acute congestive glaucoma is ruled out. So the answer is your acute anterior uveitis. Now in anterior uveitis, why would the cornea be hazy? Two reasons. One, you can have a raised IOP in anterior uveitis. Okay, and because of that, the corneal endothelial pump is not pumping out the fluid from the corneal stroma. So the corneal stromal edema. Number two, when you have anterior uveitis, you will have keratic precipitates, right? So when there are keratic precipitates stuck on the corneal endothelium, that can also lead to haziness, described as haziness of the cornea. Okay, it's not clear basically. What is the eye? I'll come to your question, BU. Okay, so you understood. So it is anterior uveitis. Now, in a severely traumatized eye, enucleation needs to be done within what time frame to prevent sympathetic ophthalmia? See, the injured eye, that is the exciting eye, has to be removed if at all you plan to remove it. And when will you plan to remove it? If there is no vision at all, there is no visual potential. So in that case, you want to prevent sympathetic ophthalmia from affecting the non-injured eye. Yes. So in that case, you enucleate, remove that exciting eye within 2 weeks of injury. Okay, within 2 weeks of injury. After 2 weeks, there's a higher likelihood that the antigen has gone into and sensitized the immune system. Okay, so it will start attacking. So if at all you want to do anything, do it within 2 weeks of injury. Is that clear? And that also only a non-seeing eye, not a seeing eye. Yes, coming to your question, BU, see, in inflammatory bowel disease, you get episcleritis, you get scleritis, you get anterior uveitis, because IBD, inflammatory bowel disease, is also associated with HLA-B27. So you can also get HLA-B27 uveitis in inflammatory bowel disease. Okay, so you can get episcleritis, scleritis, and this anterior uveitis. All right. Okay, so we are done with the UVEA quiz discussion. And what is the topic for today, guys? Oh, yeah. So today it is retina and vitreous quiz. Rheumatoid arthritis, lot of things. You get dry eye, then you can get scleritis, episcleritis. Yeah, and because of the medications for rheumatoid arthritis, we also get peripheral ulcerative keratitis, PUK. Then because the medications that you give for rheumatoid arthritis and the complications because of that. Yes, there's nothing like most common. There's nothing like most common, and nowadays they don't ask such questions. We passed such things. There's no most common maybe in rheumatoid arthritis, probably we can say most common would be dry eye. I mean, I don't have a reference for that, so please don't take that as an answer. If I find a reference in a textbook, then I will tell you. Okay, if they don't mark that answer, don't even write it down. Okay, so today we have the retina and vitreous quiz, guys, and that is at 6 p.m. on the Telegram group. And the New Year sale today is the last day, I was told. So. That is it. And the test and discussion, yes, you can join us by clicking on the link that I've given you in the video description. So every week we have 3 tests with 20 questions each, covering, based on my experience, and you have a discussion. Yes, BU. Only in juvenile idiopathic arthritis, as such, we have anterior uveitis, and that affects children. So rheumatoid arthritis as such, the chances of uveitis, yes, is there, but not that very common. It's quite rare. All right. Okay, guys. So I'll see you tomorrow at 11 with retina and vitreous quiz discussion. Okay. So any other doubts? Most welcome. You're most welcome, BU. All right. Okay, so also please do check out today's question on Instagram. So today I posted a question. Yesterday I posted the referral guidelines for thyroid eye disease, and today again it's there on YouTube as well. Let's do MCQ series. So I posted the question here. Please comment your answers. We'll discuss those questions on some other day. All right. Oh, thank you, beta. Thank you, PPT. Thank you. All right, so all of you all have a good day. I'll see you all tomorrow. Okay, bye.